Very good morning and thank you, or good afternoon, everybody. If you're on the East Coast, it is my pleasure to introduce Dr. Kimberly Martin to our division here to present this morning. I met Dr. Martin through her fellowship, which is the University of California President's Postdoctoral Fellowship Program, or PPFP, which is a UC-wide fellowship. And so Dr. Martin currently in the Department of Psychiatry and Behavioral Science at UC San Francisco, but is in 2 weeks transitioning to Yale University. And so she's going to be joining us from a very far distance in the near future. But Dr. Martin earned her PhD in social psychology from UCLA and her BA in psychology with honors and distinction from UC Berkeley. And so we were just chatting. She's a UC kid through and through. Dr. Martin's research centers on the impact of inequity and the importance of history to current experiences, perceptions, and mental and physical health outcomes of minoritized people. Specifically, much of her research looks at the experience of Black Americans in the healthcare system and tests how to improve outcomes for Black Americans by increasing the acknowledgement of and support of addressing racism. So I saw Dr. Martin's talk earlier this year at a retreat, and I thought it was incredibly fascinating. And so invited her and was very happy that she agreed to present to our group here. So with that, I want to welcome Dr. Martin, and the screen is yours.
Thank you. Thank you so much, John and Rochelle, for inviting me. I'm so happy to be here and excited to discuss my research with you all today, which is entitled Black Americans' Health and Healthcare Experiences, Understanding the Past and Present to Create a More Equitable Future. I'm going to start us off with a quote, which says, "Of all the forms of inequality, injustice in health is the most shocking and the most inhuman because it often results in physical death." And these words were spoken by Martin Luther King Jr. at a press conference in Chicago in 1966. And they illustrate a consistent reality for Black Americans, because for centuries, research and reports have documented that historically and presently, Black people experience worse health outcomes, medical mistreatment, and racism in the US healthcare system. And so, for example, Black Americans have worse health outcomes in many areas. These areas include domains such as infant mortality, breast cancer mortality, hypertension, heart disease mortality, HIV mortality, and AIDS mortality. And this is as compared to white Americans, and just to name a few disparities. And individual racism, such as racism that occurs during interpersonal interactions, and systemic racism, that is racism that operates in and is maintained by public institutions, social policies, and regularly practiced cultural norms, contribute to health disparities for Black Americans. So for example, research shows that Black newborns are 3 times more likely to die if they are cared for by white as compared to Black physicians. Research also shows that healthcare professionals are less likely to refer Black as compared to white women for mammograms. Also, Black Americans are less likely than white Americans to be referred for heart health screenings. And research shows that Black as compared to white Americans with HIV are less likely to be referred for antiretroviral therapy when eligible. And so this reality of medical mistreatment and racism has been well documented and studied for over a century. And beyond this, Black people have shared their stories of their experiences of racism throughout history, particularly in the healthcare system. And this foundational information really inspires a lot of my research and has led me to first question and then test how current healthcare experiences may be impacting Black Americans. And so I'm going to dive next into my research questions. Overall, my research questions for today's talk are: what are the experiences of Black Americans in healthcare, and how does this influence medical trust and medical decisions? I'm also asking, how can we uplift the voices of Black Americans in healthcare to better understand the problems they experience in the healthcare system? And I'm asking, what can be done to recognize and address the injustice that Black Americans experience in healthcare? And so I think about asking these questions in three ways. I'm asking, what is the problem? What is the experience of the problem? And what can be done about the problem? So for what is the problem, I'll be sharing some data with you today that focuses on understanding current healthcare experiences and medical trust as key factors in health perceptions. And this is within the context of COVID-19. Under what is the experience of the problem, I'll be sharing data with you that asks what is the nature of negative and positive Black patient interactions that may contribute to medical trust and health perceptions. And this was done in a sample of Black women with breast cancer. And then under what can be done about the problem, I'm asking what can lead to better recognizing injustice in healthcare and increase behavioral intention to change it. So let's start off with what is the problem. So over 676 million COVID-19 vaccinations have been given out just in the United States alone. But if we can think back to November of 2020, when very few Americans had received a COVID-19 vaccine, there were these national polls that were consistently showing that Black Americans were the race with what people were calling the most vaccination hesitancy. So when asked, how likely are you to try to get vaccinated for COVID-19 when a vaccine is available to you? In November of 2020, polls were showing that about 42% of Black Americans were saying that they would get vaccinated for COVID-19, and this was compared with 61% of white Americans at the time. And when these numbers were released, it spread through the media like wildfire, and this question kept coming up. Why wouldn't Black Americans want to get vaccinated? And this was especially a big question because there was data coming out showing that Black Americans were highly likely and more likely than white Americans to be hospitalized or to die of COVID-19. And it was posited at the time that there was a lack of medical trust in the Black community because of historical mistreatment. And many sources cited the Tuskegee syphilis study specifically as a reason why Black Americans did not want to get a COVID-19 vaccine. For anyone who may be unfamiliar, the Tuskegee syphilis study was where effective treatment for syphilis was intentionally withheld from Black men when it became available, which led to many of them having lots of complications, lots of death, and even spreading syphilis to their families. And so honestly, when I heard this framing that the Tuskegee syphilis study was the reason that Black Americans did not want to get a COVID-19 vaccine, I found that framing unsatisfying at best and really honestly dangerous at worst. Of course, history is extremely important. There's no doubt about that. But as noted in my introduction, Black Americans do not have to reach back in the past for experiences of medical mistreatment. Many Black Americans today have suboptimal and disproportionately worse experiences in the healthcare system. And so because I had these feelings about these reports that were coming out, I decided to collect some data on it. And I conducted two studies, one when vaccines were first being approved for emergency use by the FDA, and many Americans hadn't yet received a COVID-19 vaccine. And then I collected some more data later after many Americans had received a COVID-19 vaccine. So let's dive into study one. My research question for study one was, why are Black Americans less likely to intend to get vaccinated for COVID-19? And I also asked, what is the influence of historical and present day healthcare experiences on medical trust and vaccination intention? To address these research questions, I conducted an online study in December of 2020 via Prolific, which is an online recruitment platform for participants. I got around 300 Black and white Americans in this sample. And on Likert type scales, I asked people about their intention to get a vaccination. So how likely are you to try to get a COVID-19 vaccine as soon as it becomes available to you? I also asked about their level of medical trust. I asked, how much do you trust the medical community? And I asked about the quality of their healthcare experiences. I asked both how positive have your past experiences been in the healthcare system and how negative have your past experiences been in the healthcare system. And then I asked them about their knowledge of the Tuskegee syphilis study. First, I asked participants if they were familiar with the Tuskegee syphilis study at all. And then I basically gave them a Black history test where I asked them questions to assess their accuracy of what happened during the Tuskegee syphilis study, such as when did the study begin? And what I was hypothesizing was that Black Americans, as reports were showing at the time, would be less likely to intend to get a COVID-19 vaccine. I also predicted that Black Americans would have significantly less medical trust as compared to white Americans, and that Black Americans would report lower quality of healthcare experiences. Further, what I hypothesized is that what might be explaining this racial difference in intention to get a COVID-19 vaccine would be that Black Americans would report lower quality of healthcare experiences, which would then be related significantly to them having less medical trust and then associated with less intention to get a COVID-19 vaccine. So let's dive into the results. What I found was that indeed, much like other reports, during this time, there was a significant difference such that Black Americans had less intention to get a COVID-19 vaccine. This is again in December of 2020. I also found, as predicted, that Black Americans had significantly lower medical trust as compared to white Americans. I also found that Black Americans reported having significantly less positive healthcare experiences. However, I did not find that Black Americans reported having significantly more negative healthcare experiences. I have lots of thoughts about why I may not have found what I predicted, and I will be happy to talk about that during the Q&A or any time after the talk. So for my hypothesized indirect model here, for this serial model, we decided to include positive healthcare experiences in this box for quality of healthcare experiences because we were interested in how racial differences may be influencing trust, and because we hope to provide some actionable insights about improving experiences, trust, and vaccination intentions. So it could be the case that maybe positive healthcare experiences are really important here. And I will also note that I included covariates in all of the models that I'll be sharing with you today, including age, education, gender, and health status. And I also, per a reviewer's request, have additional analyses where I included a bunch more covariates, and all of the significances and directions stay the same in all of my results. And so I'm showing you the full model here, and I'll break down the findings. So what I find here is that Black Americans, again, reported having significantly less positive healthcare experiences. And then this was related to them having significantly lower medical trust, and then was significantly associated with why they had less intention to get a COVID-19 vaccine. And I think importantly, once you account for positive healthcare experiences and medical trust in this model, you see this racial difference between Black and white Americans and their intention to get a COVID-19 vaccine is no longer significant. As for the Tuskegee syphilis study, what I found was that Black Americans did answer the questions more accurately compared to white Americans and so essentially had more knowledge of the circumstances of the Tuskegee syphilis study. However, I did not find that knowledge of the Tuskegee syphilis study was significantly related to COVID-19 vaccination intention for the sample overall. And I also did not find a race by Tuskegee knowledge interaction on COVID-19 vaccination intention. So it wasn't the case, for instance, that just for Black Americans knowing more about the Tuskegee syphilis study was related to their vaccination intention. Similarly, I did not see a significant association between knowledge of the circumstances of the Tuskegee syphilis study on medical trust. And again, I did not see a significant interaction between race on Tuskegee syphilis study knowledge and medical trust. I'll also note that in this sample, about 66% of Black Americans and 62% of white Americans reported that they had any familiarity with the Tuskegee syphilis study at all. So a pretty large portion of both samples said that they didn't know anything about the circumstances of the Tuskegee syphilis study. And so as a reminder, these data were collected in December of 2020, when many Americans had not yet received any COVID-19 vaccination. And so we conducted a second study. This time it was collected online between March and April of 2021. And this time we had a nationally representative sample of Black and white Americans and had about 13,000 of them. And for this study, the questions were, we asked people, because more people have been vaccinated this time, how many doses of the COVID-19 vaccine have you received? This was coded as a binary dependent variable, so just yes or no, whether or not they had been vaccinated. We also asked people who had not been vaccinated yet about their COVID-19 vaccination intention. So how likely are you to try to get a COVID-19 vaccine as soon as it is available to you, like we did in study 1. We also asked about people's level of medical trust. This time we asked, how much do you trust the following professionals, doctors or medical professionals, your personal physician and medical researchers? And then we asked about quality of healthcare experiences this time by asking how much do the people in the following professions care about your well-being? And then asked again about doctors and medical professionals generally, your personal physician and medical researchers. And I'll note that this data came from a larger collaborative project called the UCLA COVID Health and Politics Project, which is a larger project happening at UCLA. And because this was a larger collaborative project, the wording and the tone of these questions is admittedly different from study 1, but I think it also allowed me to add more nuance to the questions and get a bit more specificity. And so also I'll note, because trust has been defined as the mental process by which people are able to be vulnerable with others because they have positive expectations of their behavior. What I was positing was that feeling that healthcare professionals truly care about your well-being could lead to those positive expectations and more vulnerability in patients towards medical professionals. And specifically with an interest in physician-patient interactions, I really aimed to test if feeling that your personal physician cares about your well-being could influence medical trust. Again, trying to think about actionable insights for physicians. And because I was wondering these things, I computed a principal components analysis, which allowed me to identify coherent themes for these variables. This analysis yielded 3 components, which explained about 80% of the variance. There was a medical trust component, which was trust in all of these medical professionals. And then there was doctors and medical professionals generally care about your well-being component. And there was a your personal physician cares about your well-being component. But medical researchers didn't load onto any of the components here. And so this provided evidence that people were conceptualizing care and trust differently. And this was helpful because what we hypothesized was that, again, Black Americans would report significantly lower medical trust as compared to white Americans. But what might explain that difference is that Black Americans report that their own personal physician cares less about their well-being. And then this would be significantly associated with less medical trust. And again, we included relevant covariates into this model. So as for my results for this study 2, in terms of COVID-19 vaccinations and vaccination intention, what I found here in March, April of 2021 was that there was no significant difference between Black and white Americans in their COVID-19 vaccinations. I also found no significant difference between Black and white Americans in their intention to get a COVID-19 vaccine during this time. And then as for my hypothesized indirect path, what I found was that indeed Black Americans were reporting significantly less medical trust compared to white Americans. Black Americans also reported significantly feeling significantly less that their personal physician cared about their well-being. And then this was associated with why they had less medical trust. So overall, for these COVID-19 vaccination studies that I've shared with you, what I found was that there was in study 2, at least, no significant racial differences in vaccination hesitancy and actual vaccinations at this later time point. However, medical trust is significantly lower in Black Americans as demonstrated in both studies. And I think that my studies really point to that special attention to how to make experiences more positive for Black Americans is really essential. And I think of that as an actionable change. And I think the studies also highlight the importance of understanding Black Americans' experiences in healthcare. I shared that I was unsatisfied by this narrative that the Tuskegee syphilis study, while important, an important part of American history, was the only reason why Black Americans would be hesitant, or the primary reason why Black Americans would be hesitant. And I really wanted to think about how, Tuskegee is one of many historical examples of medical mistreatment, but this is an ongoing problem where Black Americans are continuing to experience medical mistreatment. And these less positive experiences, these suboptimal experiences, these disproportionately worse experiences were really influencing their perceptions of the COVID-19 vaccine and their level of medical trust. And so I've just taken you through what is the problem. I'm now going to turn to what is the experience of the problem. So focusing on the nature of negative and positive physician Black patient interactions and a sample of Black women with breast cancer. And so first, I'm going to give you a little background about Black women with a breast cancer diagnosis. So Black American women have the highest mortality rate of breast cancer at every age when compared to white, Native American, Latina, and Asian women in the United States, but they do not have the highest incidence rate of breast cancer. And specifically, California has some of the highest mortality rates for Black women with breast cancer in the US. And this fact is particularly important to this research that I'm sharing with you today because the data that I will be sharing with you comes from Black women who all live in California. And the data that I'm sharing with you is from a project that I'm a team member on, which is entitled Project SOAR. SOAR stands for Speaking Our African American Realities, and Project SOAR is a community academic partnership between UC researchers and Carrie's Touch. Carrie's Touch is a nonprofit organization established to help Black women with a breast cancer diagnosis that is based in Sacramento, California. And in Project SOAR, we conducted focus groups and collected qualitative data led by our PIs, Dr. Annette Stanton and Reverend Dr. Tammy Denise. And we got these qualitative data through focus groups, and we have affectionately called these focus groups gatherings. With permission, I'm sharing photographs from our Sacramento gathering. And a gathering is a small group discussion to give voice to the experiences of Black American women with a breast cancer diagnosis. We think of them as culturally curated focus groups. They're an all Black and all women space. These focus groups and these gatherings included having breakfast together. There was a registration period. We had a 2-hour Q&A session that was recorded and transcribed for analysis. We had a closing inspirational speaker at each of our gatherings. And we had ended by having lunch together. Each of these gatherings were facilitated by Reverend Dr. Tammy Denise and myself. And I was just really honored to be able to be a part of this research team and to be able to speak to these women as they really courageously shared their stories. And so for Project SOAR, we collected data in March to June of 2019 in 3 locations, Sacramento, Los Angeles, and Oakland, California. And we had 37 women in total participate. I'll also highlight that we had quite a range in year of diagnosis. Some people had multiple decades of survivorship, and then other people had just been diagnosed that same year. This seemed to really add some nuanced insights, I think, to the data that I'll be sharing with you today. So the research questions for this particular project for Project SOAR is, what are the negative and positive experiences that Black women have with healthcare providers that may contribute to medical trust and health perceptions? And so we conducted formal qualitative data analysis utilizing thematic analysis to identify patterns in the gathering data and those transcriptions I mentioned. And we used multiple coders from both the community and from academia to identify our themes. And so we had 4 themes in total that were identified for this study, and they are individual and systemic injustice directed at Black breast cancer survivors, protecting myself from an untrustworthy medical system, stereotypes interfered with my care, and good care should include compassion, respect, shared decision-making, and tailored support. And so for the sake of time today, I will not be elaborating on all of the themes during this talk, but I'm happy to discuss more about the themes during the Q&A or anytime after the talk. But to share some of the results with you, I'm going to focus first on this theme, individual and systemic injustice directed at Black breast cancer survivors. And this is really where participants described the complex challenges inherent in navigating a harmful and unjust experiences from the healthcare system and from individual healthcare providers. So I'm now going to share with you some direct quotes from our participants to illustrate this theme. One participant shared about starting her breast cancer journey. She said, knowing the statistics, I knew that going in, not just when it comes to breast cancer. I knew how disproportionately we die of other diseases and we have other diseases. And I also know how the medical community is. It's a big process line. So it kind of made me feel like I was geared up for a fight, and not necessarily a fight against them, but a fight against the system. I'll also share additional quotes. Another participant shared that she was discussing breast cancer treatment options with her surgeon, and she was wondering if chemotherapy was the best treatment plan for her. And she said her surgeon said to her, if his mother were to tell him that she wasn't going to have chemotherapy, he would slap her. So we said, thank you very much. Thank you for your time. And we were out of there. Another participant said, when discussing her diagnosis with her surgeon, that her surgeon said to her, we can't save them. They're no good, but not even in a sympathetic way. She said, maybe I showed too much strength, but I just think to assume because you don't see somebody with their emotions on their sleeve that they're not feeling something, you know? I think that's what I got from the medical team, that you come in here like you can take it. So this is how I'm going to dish it to you. And so I just want to highlight that with experiences like this, it is no wonder why Black Americans have justifiable mistrust in the medical community. These medical professionals are certainly not indicating that they care about their patients' well-being with these types of statements. And this could certainly influence how much trust they have in these particular medical providers and in the medical system and in the medical community more broadly. And I also want to highlight that this qualitative data really, I think, brings to life some of the quantitative data that I have been looking at and trying to understand what people mean by less positive experiences, right? By having these really vivid and really awful examples of disrespect towards Black patients in the medical system. So I'm going to turn now to the theme, good care should include compassion, respect, shared decision-making, and tailored support. This is where participants describe the type of care that they wish they had received during their breast cancer journey. For instance, some participants said that they wish they had been offered a clinical trial or been given options for the type of breast cancer treatment that they would receive, rather than just being told what they needed to do. Or given options about mental health services, or options to use a patient navigator. And so as a direct quote from a participant, she said, it would be nice if they could show a little more compassion, because this is a brick on you, you know? But when people do that, it kind of opens them up. They're kind of vulnerable too, but it would be nice if they could take your hand and say, I know this is going to be difficult for you, but we're here for you, you know? It doesn't take anything, but I don't think they realize it. I mean, it's something that could be part of the continuing education or something, staff meetings or something, you know? Open yourself up a little bit, you know, doctors and nurses, and show more compassion for the person that's going through this, that's getting this news, not just, hey, it's during our office hours. If we want to we have to make these calls and here, blah, blah, blah. And so from this study that I've just shared with you, I think it really highlights the importance of uplifting Black voices in the healthcare system to understand the specific situations that they are experiencing. It also highlights the importance of understanding what is happening in these interactions and exposing and addressing those problems, such as blatant disrespect. And it also highlights that, and really indicated to me that in order to better understand the perspectives of Black Americans, it could be imperative to learn their stories and their experiences of injustice. And so I've just taken you through what is the experience of the problem. And I'm now going to turn our attention to what can be done about the problem by thinking about what can lead to better recognizing injustice in healthcare and increased behavioral intention to change it. And so a critical step towards dismantling racial injustice is acknowledging that it exists. However, research consistently shows that white Americans specifically do not acknowledge that racism exists in many domains, including healthcare. So when Black and white Americans are asked about if Black people are treated less fairly than white people in the US when seeking medical treatment, Pew Research consistently finds these racial gaps. In some of their latest data, they found that 33% of white Americans said that Black people are treated less fairly in the healthcare system, and that was compared with 76% of Black Americans who said so. And so what is interesting here is this gap, right, between Black and white American perceptions, but it's also the question. The question is, how are Black people being treated? And so it makes sense that Black people would have more insights into how Black people are being treated in the medical system. But it also highlights that because of all of the data that I've been sharing with you, including my introduction information and my own data, there is a correct answer here. Black people are treated less fairly in the US healthcare system. And so what these data are showing is that white Americans are much more likely to get this answer incorrect. So what can be done about this? Research shows that learning about Black history can help with this. And research demonstrates that when white Americans engage with Black history, they prefer what is called celebratory Black history, or history that focuses on Black Americans' achievements. However, when they learn critical Black history, which centers the experiences of injustice that Black Americans face, this can lead to more racism recognition. Additionally, research shows that perspective taking with others can help with recognizing racism. So research shows that when people perspective take, which is imagining what someone such as a Black American might be thinking, feeling, or experiencing, this can lead to improved intergroup attitudes and more acknowledgement of current discrimination. And while these literatures have looked at similar outcomes, they have remained largely separate. Also to date, most perspective taking research, and there's a lot of it, but it mainly investigates the outcomes of perspective taking rather than on how to engender perspective taking. That is, typically, perspective taking methods instruct people to either perspective take or not, so it's a manipulated independent variable. And so for me, after spending so much time myself in this research, learning about the experiences of Black Americans in the healthcare system and having my own experiences as a Black American in the healthcare system, I really started to wonder about the utility of learning about these Black American experiences in healthcare. And I wondered if people learned about what Black people go through in the US healthcare system, could this lead to perspective taking? And so for this final study I'm sharing with you all today, I looked at, can learning about Black Americans' experiences of injustice lead to increased perspective taking? I also looked at, can this increased perspective taking then improve intergroup perceptions and behavioral intention to change the healthcare system? To address these research questions, I conducted another online study via Prolific and got over 1,400 white Americans in this sample. And what I did is I randomly assigned our participants to learn one of 3 Black history lessons. You might notice the theme, I like teaching people Black history in my studies. And they were randomly assigned to learn either a critical Black history lesson, a celebratory Black history lesson, or a control Black history lesson. These lessons were in the context of healthcare. They all included 5 pictures with captions describing what people were looking at. And the pictures ranged from the Reconstruction era, so about 1865, to the present. So as an example, in the critical Black history condition, participants saw this picture. This is a picture of Fannie Lou Hamer, who went to the doctor for minor surgery in the 1960s, and instead the doctor removed her uterus without her consent. Hamer became the victim of forced sterilization, and this was disproportionately happening to Black American women during this time. That is an example of critical Black history in healthcare, or racism in the healthcare system towards Black people. In the celebratory Black history condition, participants saw, one of the photos that participants saw was this one. This is Dr. Patricia Bath, who became a medical doctor and specialized in ophthalmology, and she actually created a laser to remove cataracts. So this is an example of celebratory Black history in healthcare, showing Black American achievement. And in the control condition, participants saw almost like stock photos of Black Americans with just a description, such as what the person was wearing. And after participants received one of these 3 Black history lessons, they answered questions, one of which was about their level of perspective taking. So on a Likert type scale, they were asked if they imagined what the person in each picture might be thinking, feeling, and experiencing. They were also asked about their support for policies to address racism in healthcare. So this was a measure that I adapted from Senator Elizabeth Warren's Anti-Racism and Public Health Act, where participants were asked if they supported specific anti-racist efforts that were being proposed to address racial inequality in the healthcare system. This included things like the US government should create a national center for anti-racism and health within the CDC, and efforts should be made to educate the public on the public health impacts of racism. I also asked participants about their attributions for health disparities. So this scale was assessed, or was adapted from a scale by Price and colleagues, where I assessed if participants attributed health disparities between Black and white people to systemic societal problems. And specifically, participants were explicitly told that research shows that there are currently health disparities in the United States such that Black Americans have poor health in many domains as compared to white Americans. And then they were asked, how relevant do you think each item is to contributing to these racial health disparities? And these systemic examples included things like the persistent level of discrimination in society against Black Americans, as well as the poor quality of healthcare received by Black Americans. And what I was hypothesizing was that learning critical Black history compared to celebratory Black history and this control Black history lesson would significantly increase perspective taking. I also hypothesized this indirect path, or this mediated path, such that when white Americans learned critical Black history compared to those other history lessons, they would have significantly more perspective taking. And when they did both things, so they learned critical Black history and they had higher levels of perspective taking, they would have more support for anti-racist healthcare policies. And when they did both of these things, they would be more likely to attribute health disparities to systemic level issues. So let's dive into the results. To orient you to the graph, on the x-axis here, I have the Black history lessons that they were randomly assigned to, either critical, celebratory, or control. And on the y-axis, we have level of perspective taking, with higher numbers indicating more perspective taking. And what I found here, as hypothesized, was that when white Americans learned critical Black history about Black Americans, they had significantly higher levels of perspective taking as compared to when they learned celebratory Black history or that control Black history lesson. While I didn't hypothesize this, I also found that when white Americans learned a celebratory Black history, they had significantly higher levels of perspective taking compared to the control condition, but the effect sizes were much larger for that critical Black history lesson. And then I also found that, and I'm showing you the full mediation path here, but for ease of the figure, I'm just showing you critical Black history versus control Black history, but the results and significances look the same when you compare critical versus celebratory, just a note. But when white Americans learn this critical Black history lesson versus the celebratory or the control condition, indeed, they did have significantly higher levels of perspective taking. And that was, when they did both of those things, that was then related to having more support for anti-racist healthcare policies. And I see a similar result here. We look at critical Black history versus those other history lessons. They had significantly higher levels of perspective taking. And then that was then associated with attributing health disparities to systemic issues, being more likely to do that. And so my research really aims to reduce racial inequality and inequity in healthcare. And my research and understand it better, right? And then my research also has societal implications. My findings suggest that learning about outgroup members and about Black Americans specifically can lead to taking the perspective of minoritized people and can lead to more support for improving inequity. However, historically and presently, stories of racial injustice are being actively silenced. Here is a map that shows states that have either signed bills into law or are proposing to do so that restrict the teaching of race and racial injustice in the classroom. So in blue here, we have states that have signed these bills into law, and in purple, we have ones that have proposed it. And then there are other states who, such as California, our own state, and Connecticut, that are currently proposing to expand the teaching of race and racial injustice in the classroom. And so this is a really contentious issue right now about whether or not people should learn an accurate history about race and racism. And I'm hoping that my data and other people who do similar work can really showcase and highlight that learning an accurate history of racism, understanding our history and Black history around racism can really lead to these positive outcomes, such as perspective taking and then support for addressing racism. I'll also highlight that my research itself has been helpful to the Black community. We have some indicators. And so specifically for Project SOAR, we did follow-up surveys with our participants, and they reported that they were positively impacted by the gatherings themselves, by this community academic partnership. And they said that what happened for them is that the gathering provided a safe space for them. It facilitated connection with other breast cancer survivors, and it empowered them to have self-advocacy with their medical team. And so I think this highlights the necessity of this type of research in building community and working with community members to uplift their stories. I'll also highlight that my research is relevant and has implications for HIV research and for HIV physicians. So here I'm highlighting the HIV care continuum, which talks about these steps for people with an HIV diagnosis. And this is happening at an individual level, right? Thinking about how individuals can be interacting with their physicians during these physician-patient interactions and with the system to keep them in care, right? And to keep them on medication. So making sure at this level that doctors are indicating that they care about the well-being of their patients, that they're building trust with their patients through demonstrating their own trustworthiness through their actions, I think is really imperative. And it's also important to remember that at this individual experience is nested within a larger system of inequity in the healthcare system, right? This larger system treats Black people worse and with discrimination generally and in the healthcare system specifically. And this can negatively impact Black people's health and their well-being. I'll also highlight even this, though, is not the full picture because it's also important to note that these individuals and these systems are set on a foundation of history, right? For example, Black patients with an HIV diagnosis have a history with medical professionals before ever seeking HIV treatment or learning of that diagnosis. And so if their previous personal history and their previous encounters with specific doctors and within the healthcare system have indicated to them that they are not cared for, this could lead to justifiable mistrust in future encounters with physicians. Also, our own healthcare systems have histories that lay a foundation for the disparate treatment and discrimination that is perpetuated against Black people. And so listening to and believing Black patients and changing individuals and systems led by their input is really important. And so ultimately, my research highlights the importance of Black stories and the consequences of those stories. In my first set of studies, I look at the potential influence of knowing about the Tuskegee syphilis study versus people's own stories. In my SOAR data, I highlighted that we showcase the importance of Black women with a breast cancer diagnosis and how their own personal stories and histories in healthcare was influential and important to listen to. And then finally, I showed that when white Americans learn about Black stories of injustice, this can increase their perspective taking with Black Americans and improve their intergroup attitudes. So overall, through my research, I'm really seeking to better understand and address a complex and really multifaceted problem, which is the experiences of racism of Black Americans in the healthcare system. And I think a problem like this should be studied using multiple and different lenses. And that's why I share data with you from a nationally representative large sample. I did some qualitative data analysis, and I also did some social psychological experiments to really try to deeply understand this problem and address it. And so in closing, I'll just share that currently, as John mentioned, I'm a UC President's Postdoctoral Scholar here at UCSF. I will soon be starting a postdoc at Yale, where I'll be continuing my work and specifically looking at how to improve physician-Black patient interactions by doing interventions with physicians and medical students with the aim to increase their perspective taking with Black patients, and really improve those interactions and ultimately improve Black patients' perceptions as the system and individuals become more trustworthy, and improve Black patients' physiological health outcomes. And with that, I would just like to thank all of my mentors and participants, all of my funding sources, and all of you for your time and attention. Thank you very much.
Great, thank you so much, Dr. Martin. So round of applause for that. Let's see, so we'll open it up to questions here. So please feel free to unmute and ask or post in the chat and I'll read it. Don't know if there's any hands up. Questions? See Wayne unmuted. Go for it, Wayne.
Yeah, thank you for this. This is a great presentation. I have just maybe a very practical researcher question based particularly on some of the first studies that you were talking about, and that has to do with what recommendation we would make. So I'm on a number of studies that work in healthcare settings where you're trying to ask patients about their experiences in a care setting, and you're trying to do it through these surveys that often have to be run. They have to be very short because, you know, the patient burden is high and everything else. And you do have these kinds of problems, which it's difficult to get people to say they dislike their doctor as just a general phenomenon overall. And then you layer all the issues about race and everything else on there, and you get all this kind of social desirability against saying negative things and stuff like that. So if you had to make a recommendation about, if you only could do a couple of questions, like what would those questions be that you think would be best at getting at kind of meaningfully discerning whether a person is having a better or worse experience, and do so in a way that could be useful for a clinical site and for a researcher?
Yeah, that's such a great question. And that's really tough, right? Because I think like my own experience with the research is that I think a lot of what allowed people to be like honest and vulnerable about their experiences was like when we sat down with them and spoke with them, like, right. So like in the Project SOAR data where we had an all Black and an all woman space and we were there to serve them and we made that very explicit. And then it felt like that opened a door for them to be like, okay, this is what's really going on. And I don't think that we would have gotten that by giving them a survey. And so like, as a person who does a lot of quantitative research and also does qualitative research, like that's tough for me, right? Because it's like, I like having big numbers and looking at breadth, but I also need to get the depth. And so I think, I don't know if I don't want to punt your question, but like, I don't know if there's like a specific question that I think could get that kind of depth or level of honesty. But I think trust would be a main thing. Like if they feel that where the people who are assessing the questions really care about them and that they can be trusted, right? That's just like any survey, right? Like if you think about like when you're leaving a job and they say, oh, take a survey to tell us, what your experience was like working here. And it's like, how can I be honest? Because I don't know if I can trust what they're going to do with the data. So like, I think it's the same kind of hesitancy and being honest. And so if the questions are coming from, there's indicators that this research is being done for them to help them then and you can indicate trustworthiness, respect, compassion, empathy with those people, then I think that could, open the door for them to be a little bit more honest. But I don't know what the specific question should be, particularly. Yeah.
Yeah, thanks. So let's see, other hands. I see Tor had a comment about any of this data, Kim, was longitudinal or cross-sectional, and how you think about limitations and future planning.
Yes. So no, it was not longitudinal. Some of the first set of studies that I showed you, the COVID-19 vaccination studies, were cross-sectional. So yes, all the limitations, right? I think that, for me, in thinking about hypotheses and thinking about sort of these indirect models, I think it would be a shame not to look at how these things could be related to each other in a model, and then also admit that there are limitations to thinking about it this way. But then there are certain things that we just cannot experimentally manipulate, right? Like race, which is really a proxy for racism and cultural experiences in this country. And I can't manipulate that. So, but I can show those racial differences and then highlight that, these differences are not happening, because somebody is Black. It's happening because of racism and these experiences in the healthcare system. So yes, I think there's caveats, there's limitations to every study, of course. And so I'm just trying to continue to build, with future work, I'm now taking this perspective taking manipulation into the lab and having participants come in. I've been working on some of this summer, and seeing what it's like after they get this Black history lesson and then they actually interact with a Black person in the lab. If their perspective taking they're saying that they're perspective taking at least with the people that they're learning the Black history lesson about, but are they perspective taking with somebody they meet the next day? And so I'm looking at some of these things to try to build out more and get more evidence for what I'm thinking is effective. But yeah, that's where I'm at. Thank you.
That's great. Thanks, Kim. So mindful of the time, we have about 6 minutes. I see Barbara, Willie, and then one more. I'm not sure how to pronounce your name, so I apologize. Iberi. So we'll do that order: Barbara, Willie, and then go. So go for it, Barbara.
So I will go very quickly, Dr. Martin. Thank you for this research. It's really, really inspiring. So thank you very much. I will also say that I was in and out of your talk. I apologize for that, but I'm wondering if you spoke about whether or not Black people feel like they're entitled to good health. Because I look at, sometimes I think about internalized racism and how we don't feel like we're entitled to certain things because of that internalization. And I was wondering if any of your work looks at that. And I absolutely love your work on Black history lessons.
Yeah, thank you. So no, I don't have data and I have not looked at that. I think that that's interesting. If I had to hypothesize about it, I think that Black people really are seeking to have better health outcomes and better health care, right? I think that that desire is there, and we see that even in if we think about birthing outcomes, right? Where there are other ways of thinking about using doulas or other things where maybe you would get better care. Some data are showing. And so I think that desire to be treated better in the healthcare system is there. And I think that the desire to improve health outcomes are there. I think my research really wants to focus on, not problematizing the person who's experiencing discrimination, right? And thinking about how they can be better served. If they had the same access to resources, if they had the same level of respect when they walked into the doctor's office, how that could improve their health outcomes. That's what I'm thinking about.
Thank you.
Willie.
Thanks so much. Thank you so much for your work and your presentation. I've got a comment in the chat. Just want to uplift the institutional violence that makes all of this, that has made all of this not obvious up to this point. Thank you for the work that you've done. And also just in I wanted to respond, just offer a comment, respond to the questions. I can't remember exactly what it was, but the in my experience, in my various trainings as a somatic therapist, and in doing DEIJ work, it's not only the questions to be able to get us access, to access feels like a problematic word, but to be able to help those who are marginalized share their experiences. That this is a nervous system issue that I've found in my own, conducting some qualitative research. There's pacing, and there's a pacing to patriarchy. There's a pacing to racism. There's a pacing to those who have been taught to take up less space. And that fast clip will, let a lot of people will hold back. So that when we start to do the work of dismantling this stuff inside of us and look at our nervous system, people will naturally feel more inclined to offer up more, is what I found from a personal, my own perspective, as well as those that I work with doing qualitative research with, historically marginalized, oppressed folks. So just wanting to offer that as well.
Thank you.
Yeah, thanks, Willie. And our last question, and please stay on if you can. Iberi.
Hi, yeah, thank you for this presentation, Dr. Martin. It was an excellent presentation. One thing that I would like to know more about is the stereotypes that the Black women felt that they experienced.
Yeah, so thank you for that question. So one thing that came up a lot, and we actually have a separate Project SOAR article that recently came out about this, was the strong Black woman stereotype came up a lot. Physicians indicating them that they thought that they were very strong, and so they were treating them that way. There were reports of women saying, it, like, as the doctor is telling me these things with not indicating any empathy, any emotion, and I'm thrown, right? Like this is a huge burden on me, and that in some cases it wasn't as prominent or as prevalent as these negative experiences, but in some cases there were examples of Black women really, there were lots of instances of Black women advocating for themselves and calling these doctors out, and in some rare cases the doctors did shift once they were called out about those things, like, hey, wait a minute, you can't I'm not getting the care that I need from you, and then those doctors actually shifting how they were treating those patients. But sometimes it also took like them, navigating the healthcare system, finding somebody else. But yeah, I think that was a main one that came out, were these strong Black woman stereotypes, or just negative perceptions of Black people more generally. Just kind of talking over people, treating them like they were just a number in the system rather than a person who really was seeking their care. So just sort of this general disregard also came up.
Great. And so with that, thank you so much, Dr. Martin, for a fascinating talk and engaging discussion. I think it is such a clever use of, traditional kind of social psych methods that we don't obviously get to do too much of here in the medical school, but that's always kind of, I think, a creative way to solve some outstanding health challenges. So thank you for that. And thank you everybody for staying. And have a good afternoon.